Well, thank you very much, Eyal. I think we're on time, so I think we will be finishing in a reasonable time. And we come to our main feature speaker, or guest speaker. Of course, everybody was phenomenal. Thank you very much. Our guest speaker comes from Canada. He is the world-renowned, probably, authority on sudden cardiac death. And when I Googled his name, I mean, he's probably bigger than life when it comes to sudden cardiac death. Dr. Andrew Krahn is the president of Canadian Heart Society, and he was very grateful to come to talk to us tonight. Especially, he just came from the airport literally a couple of minutes ago. So thank you, Andrew, for coming.
Thank you.
You want to put it here?
Are those my slides?
No, I don't have your
Okay, because I didn't send them to you. I thought that was pretty miraculous. Thank you very much for the kind words. That's a better introduction than I deserve. I have to say that being the president of the Canadian Heart Rhythm Society is not a very glamorous job. There's only about 200 of us in Canada, and it basically means I have to read all the complaining emails. So when this happened about 2 years ago, when I became the president, and I told my mother, Mom, I'm proud to be the new CEO of a $20,000 corporation. So she wasn't, somehow she wasn't all that impressed. Okay. So I left my office at 10 o'clock this morning, and I actually could have driven here faster than it took to fly here. There was an accident on the highway. The highway was closed. I just barely made it. And we sat on the tarmac for about 2 hours waiting for a gate to open at Newark. And here I am. So anyway, I'm very pleased to be here. Thanks for the invite. And I actually came through the side door, so I didn't know, but that's apparently what your hospital looks like from the front. So anyway, what I wanted to do today is, this is the sort of official stuff, but what I wanted to do is essentially show you 3 cases and some lessons learned from 3 cases about risk of sudden death. Maybe try to stretch your brain a little bit about thinking about this as a more complex problem, and realize that I think we're very much at the beginning of the journey of trying to understand this. And one of the things that comes up, and no criticism of our previous speakers, but I think we think of sudden death as, now that we have ICDs, we have treatment for prevention and so on. But when it all comes down to it, we really don't understand it very well. And so our treatments are not, the fidelity of an ICD is not great, right? You just commented that we put ICDs in patients, and they have a 25% reduction in mortality, and they have 7% absolute mortality benefit. That's great. But what that means is we still have to tell our patients. Most patients who get an ICD don't use it. So that tells you we're not very good at picking them, and we're still only scratching the surface of the iceberg, if you like, of sudden death in our population. So I'll start by telling you about Michael. Sorry about that. So Michael is 51. He's from a big family. And he had a cardiac arrest, and he got defibrillated in the field. He was somewhere public, which makes him one of the lucky 5%. And after he was defibrillated, he came to our hospital, and he had a cath and an echo. And to everyone's shock, it was normal. And that's the result in somewhere between 5 and 10% of patients who have a cardiac arrest who survive. And the question is, why would somebody have a cardiac arrest and not have coronary disease or LV dysfunction, which is the big driver? It's the elephant in the business of cardiac arrest and sudden death. So here's his ECG. There are probably trainees here I would be, at home, I would be inclined to pick on, but I'll take the liberty of not picking on some of the younger faces and say that I think most of us would argue if this was in a pile of ECGs to read on Monday morning, you wouldn't find anything terribly striking here. And so now the question is, if he's got some cardiac reason for this, it's lurking in the weeds, and the question is, what can we do to bring this out? So here's his resting ECG. And so I came around as the EP service with my fellow to say, we're seeing him, he needs an ICD, what should we do, this kind of thing. I went through the story, and he says that 4 of his siblings have actually had sudden death. And this was called a heart attack. And when I asked, what was the basis of the heart attack, did they have heart disease beforehand, those kind of things. 2 of them had clear suggestive evidence of coronary artery disease. They were atherosclerotic, they had a terrible lifestyle, they'd had previous cardiac disease, and then they died suddenly. But 2 of them were really unheralded cardiac arrests and sudden deaths. And so the question is, what's going on? So one of the interesting little pearls that came up, let's see if I've got it on the next slide, So one of the little interesting pearls that came up was the comment that he had a 13-year-old brother who drowned. And of course, there's a very small number of people in this room think, oh, he drowned. Oh, that's interesting. But of course, it's not specific at all unless you're in the little microcosm of the world that I live in. But the reality is, if you have a big family and a bunch of people are dropping dead and you have somebody who drowns, the thought process is maybe there's something in the clue about drowning that would give us an idea of what might be going on in this family besides what you would think would be coronary artery disease. And so as somebody who works in this area, drowning is specific to two inherited conditions that lead to sudden death. One is a form of long QT syndrome, and the other form is called catecholaminergic VT. And again, the thought process is, what would we do to try to unmask those kind of unusual causes of cardiac arrest? So long QT would be the most common of those potential mechanisms. So I just walk you through that again here and say, you know, the easiest way, people ask me, how do you measure the QT interval? The easiest way to measure that is what's called the maximum slope technique, which is illustrated here. I don't have a pointer, do I? No. So we'll use my mouse. Try to use my mouse. So essentially what we're doing is, oh, thank you, is taking a line through the maximum slope of the T wave and looking at where it intersects with the baseline, and that constitutes the end of the T wave. And when you have a nice normal shaped T wave, it's easy to measure. But when you get flattening, ST depression, and you get a bunch of abnormal repolarization parameters, then you get then it gets a little tougher. So this is a good technique for measuring the QT interval. And we get an absolute QT interval of 450, and it corrects because his heart rate's relatively low to 430, which is just below the upper limit of normal for a male. So he doesn't appear to have a long resting QT. So we thought, well, this is one of my interests, is how do we provoke evidence of a QT problem, and one of them is with exercise, because we know these patients get their events when they exercise or when they swim or those kind of things. So here's his resting ECG when he came for from his treadmill test, and then he stands up. So now we've done a test to try to provoke whether he can shorten his QT interval when he stands up. And if there are people here who don't look at ECGs regularly, the previous ECG did not look like long QT syndrome, and this ECG looks like long QT syndrome. I mean, the QT looks very long. The intern's rule, as I call it, is the QT should be less than half the RR interval, and the QT is most of the RR interval here. It looks very long. And we give him a little time. We let him do some more exercise, and the QT still looks pretty long. We keep going at peak exercise. The QT is basically the RR interval. He can't get it much shorter than about 340 milliseconds. And in early recovery, this is one of the more recent observations, is that in early recovery you really see the long QT interval. So again, if you don't see the explanation, try to provoke the abnormality. This is sort of the culture difference. Here's our echo friend. There's two types of people in cardiology, right? There's the EP people who like to stir up trouble, and everybody else likes to make it go away. So you go to the EP lab and you get VT and they go, cool. You go to the cath lab and they get VT and they go, oh no, call EP, right? So we like to stir up trouble. So this is one of the principles, is if you don't see the explanation for the problem, try to provoke it, try to unmask it, because where do you want that problem to happen? You want it to happen in front of you, not when they go home. So, pardon me, the good news for this is we now have access to genetic testing. For those people who perceive that Canadians sort of sit in igloos and wait to die and have a miserable life, we actually have paid for genetic testing for our patients who have suspected long QT syndrome. This family is actually part of a founder mutation, the most common form of long QT syndrome, long QT1. And this is part of the genetic report on this patient who has a mutation in his long QT gene. And I think in the interest of time, I won't go into that in great detail. But the really good news is, so here are the people whose deaths, when we sort of went into it in detail, we think were probably attributed to long QT syndrome. But here's the really great news, is there were 19 family members that we identified who were gene carriers for long QT, who were effectively cured by taking beta blockers. And so, although Michael was lucky, and his brothers weren't lucky in terms of where he had his cardiac arrest, these 19 family members, they're not all in this pedigree, but these 19 family members have virtually zero risk of sudden death attributed to long QT during their lifetime. And their lifetime risk without a beta blocker is in the order of about 10%. So the index case teaches us something about the larger picture. Okay, so that's esoteric Krahn and his little world, monogenic Mendelian genetics, which is actually responsible for a very small portion of what we're dealing with. So let's ask the bigger picture, which is, I think, why we're here, which is the larger population concern about sudden death. So if we look here, this is classic Meyerberg epidemiology of sudden death. So if you look, for example, at these people who have a low ejection fraction or who have had a previous cardiac arrest, their risk of sudden death is in the sort of 5 to 20%. These are the highest risk people, which is why we are advocating putting ICDs in them. But the reality is most sudden deaths, those 335,000 sudden deaths that you see in the US, happen in people in the general population who have some coronary risk factors. They may not have much coronary disease, or they have a little bit of coronary disease, and they don't have advanced coronary disease. Their risk is sort of in the 1%, 0.1% range, 0.01%. So if we're really trying to stamp out sudden death for the population, we can't just take the highest risk group people, because that'll affect a very small amount of that larger population. Okay, so does it matter? We've talked about coronary disease and so on at length. Does it matter what your family history is? So let's start with some basic epidemiology. So there's 4 nice studies that looked at families where you have sudden death in your family and asked what your personal risk is. Okay? So these are 4 different, these are largely Caucasian populations from Western Europe. But the principle of this is that if you have a family member who's had sudden death, you are at increased risk for sudden death. And that's after adjusting for the fact that you might have a similar blood pressure or cholesterol as your father did or something like that. And in fact, if you have 2 family members with sudden death, your risk goes up 9-fold. And that's independent of your coronary status or coronary risk factors. Okay? And that includes if your grandmother is 80 in a nursing home and dies in her sleep. So it's not Michael, who's 50, who has a really unheralded cardiac arrest. It's any sudden death in your family. So you are at increased risk independent of your coronary risk factors. So I'll tell you about Doug. So Doug's 47. He's healthy. He's sort of a crunchy granola burger type of guy. He likes to read, sits, smokes his pipe or a cigar or a cigarette. And his wife comes home from work one night, finds him actually sitting in bed, propped up with his book, and his book's on his chest, and he's dead. And Doug has an autopsy, and he has a 25% lesion in his proximal LAD, no thrombosis, no plaque rupture, no established infarction. Retrospect says had a little bit of heartburn for the couple weeks beforehand, so maybe that was part of it. But never had any symptoms, wasn't taking any pills. So he's 47 and this happens. So this is Doug's sister. So Doug's sister comes to me and says, am I at risk? I mean, I take better care of myself than Doug did, but he's my brother. Am I at risk? So the wrinkle in this story, this is my wife. And so this was my brother-in-law. And now my wife is a little bit worried, along with her other siblings, about what this means for her. So this is actually not a secret, that she has an increased risk. I've told you that from those previous papers. So we recently applied for, actually a little while ago, we applied for more life insurance. And so my wife and I did our health survey thing, and we had to, give blood and urine and fill out everything and so on. And I have a number of invisible health problems. But the bottom line was the insurance companies knew that she was at higher risk. Even though I'm the male, I'm a little older, I should be at higher risk. Because of her brother, they charged her higher premiums. She exercises 6 days a week. She walks 50 miles a week. She's like a psycho exercise health nut. And there's nothing she can do to get her health premiums down because of her brother. So the insurance companies have known for a lot longer than medicine has known that we are at risk because of our family history. So in the end, the model I'm going to try to pitch to you is this notion that a bunch of things come together, and we have attacked the low-hanging fruit, which is the coronary risk factors in effect, or the severity of your coronary disease or LV dysfunction. But in fact, it's a whole bunch of these things, including your genes, your repolarization genes like Michael's long QT genes, other genes, drugs, electrolytes, environmental factors. And we've gone after what we know, but it's actually only a fraction of it, which is why we're largely not preventing sudden death. And of course, your genes can manifest in a bunch of different ways. So one way, they can manifest right at the gene level, but the genes can affect things like transcription, protein synthesis, how that then gets constructed into cells, into whole organ systems, and how they manifest. So there's a bunch of different interesting things we can talk about later in the question and answer period if you want to know about how it's not just at the make a protein phase, it's actually a number of these phases that lead to alterations in how our genes function. So if we take our cardiac arrest population, this is the typical workup for cardiac arrest. And for you sitting at the back, I'll read through some of this because it may not be too easy to see. So the first thing we do when you have a cardiac arrest after you're lucky enough to survive is you have your ECG and you have your telemetry. That looks for any evidence of obvious infarction or LV dysfunction. Then you typically image with an echocardiogram. And so what's different is, although 90% of patients have an explained cardiac arrest on the basis of coronary disease or LV dysfunction, the other 10% usually need some kind of push to help you understand it. And so what's different about this, and what I would advocate doing is when you have a patient like Michael, where they don't have an obvious explanation for their cardiac arrest, the things to do are to scratch the surface a little bit. And scratch the surface usually with a cardiac MRI. That can show evidence of occult infarction, sarcoidosis, occult cardiomyopathy that you don't recognize with an echocardiogram, and myocarditis, things that can easily be missed with an echo. And provocation with things like exercise. So one of the paradoxical things is to do a treadmill test after a normal cath, because treadmill tests are for arrhythmia, like they were in Michael, not just for coronary disease and ST segment shift. And then provocation with things like adrenaline and procainamide to unmask some of these other inherited causes of cardiac arrest. And then genetic testing really stems from what you find with that type of testing. So we have a network across Canada. I must have deleted the slide. We have a network across Canada where we have 15 centers that all look after these patients with either familial sudden death, unexplained cardiac arrest, or their family members. And this was one of the cases that came up where, so this was, this guy's name was John. He's 44, smokes 6 cigarettes a day, works in construction, never had any problems in terms of medical problems, takes no pills. Tried to quit smoking a few times. He's got it down to 6 cigarettes. And he has a cardiac arrest while at work. So he gets defibrillated. He's lucky to be at work. They have an AED, he gets defibrillated. And this is his resting ECG. And again, although the quality isn't great, I think it's fair to say his ECG is not terribly compelling. So he has a cath and he has a few minor luminal irregularities in his LAD and his right, but certainly no flow-limiting lesions. He has a normal echo, and then he comes to us, actually transferred from an outside hospital for an ICD implant. So what's interesting about John's story is we went to see him as a team, at a resident, a fellow, said hello, how are you, blah, blah, blah. And you know, we went through this thing, anything running in your family, those kind of things. No, the answer was no. But I have a resident who is very, very obsessive. And so she went around to do rounds the next morning when he was supposed to go for his ICD, and he said, how are you, John? Anything happened overnight? Do you have any questions about the surgery today? Everything was fine. He said, anything happened since we talked last night? And he said, no, had a little shoulder pain. Other than that, it was fine. And she said, oh, what's the shoulder pain about? And he said, well, yeah, I get this every once in a while. You know, it's just a little sort of ache in my shoulder, lasts for a little bit, and then it goes away. Oh, okay. And so she said, what time was that? He said, oh, about 7:30 or so. So then she went to the telemetry in case something was going on. And the telemetry was a little bit interesting. So what was interesting that happened with telemetry is John was very hairy. He was one of these guys with, you know, looked like a bear. And so, and he'd been in hospital for a few days, and because the electrodes were always causing artifact and so on, the telemetry alarms had been turned off because they kept going off over and over again because they couldn't get the electrodes to get a good signal. And so you can see here, you know, look at this compelling progressive ST elevation, tombstoning, PVCs, bigeminy, this stuff. And then, you know, a storm, you'd think, you know, how can that be shoulder pain and nothing else? And then, but amazingly, after it resolves, ST segments look normal, rhythm looks totally normal. It's not artifact. You see here it says alarm silenced. And what my resident, her name was Daisy, what Daisy did that was amazing is she went through full disclosure, which is a very painful thing to do on your telemetry, to troll through the entire monitoring period to try to look for something to happen. But she found this, and we now have an explanation for his cardiac arrest. So in fact, it turns out in that segment of patients, about 5% of unexplained cardiac arrest can be attributed to spasm. So we took him back to the cath lab, gave him ergonovine, and that 20% LAD lesion turned into an Applicor. Reproduced his shoulder pain. He got bigeminy during that, gave nitro, it resolved, and then we have our diagnosis. Something interesting we can come back to talk about is what you would do about that. Whether you're satisfied with medical therapy, whether you want to intervene either from a coronary perspective or from an ICD perspective. So here's our registry, and we're trying to study this on a systematic basis, and this is, I think, part of the reason maybe why Dr. Aziz found me in Google. Certainly not a world authority, but interested in this area. So this gives you an example of the spectrum of things that happen when you dig a little harder for the genetic causes. So first of all, if we go back about 20 years ago, all these patients would have been idiopathic VF or unexplained cardiac arrest, and about half the time we're finding an explanation. 2/3 of those explanations are things like ARVC, long QT, Brugada, CPVT, things that are typically inherited or typically monogenic inherited conditions. And then the other third are things like unrecognized myocarditis, coronary spasm, early repolarization, something that's an interesting but controversial area in our neck of the woods. And so this brings me to my next point, which is a picture of our inherited arrhythmia clinic that we have. And so this is something that's a relatively new thing that's emerging. It's relatively unpopular in the United States because you can't make any money doing it because you stand there all day talking to families. It's a very inefficient thing to do. But the reality is that what you do is you see patients. So here's me sitting on a chair. Here's an exercise tech. Here's a research nurse. Here's a trainee. And here's a family of 4. This girl has long QT. You notice how there's a strong family resemblance here? And the question is, what is long QT? What does it mean to her? What do we give her advice in terms of drug therapy or exercise advice or the role of an ICD? And then, importantly, what does it mean to her sister? Could she have it? Where did it come from? How broad is the net cast for long QT syndrome in this family? So we see groups of people. We talk to them about things like drownings are specific for long QT and CPVT. Things like SIDS, 10% of SIDS is caused by inherited arrhythmia conditions. Things like single vehicle accidents that are unexplained, which potentially represent somebody essentially having syncope at the wheel. Or miscarriages. For somebody with frequent miscarriages may have a genetic condition. So these are the kind of questions that go beyond the simple question, does anybody else in your family have heart disease? And then that systematic testing we talked about. So now let me show you one other case, and that's an elderly lady who came in. She had 4 hours of sort of substernal chest pain, infralateral ST elevation, came to emerge with chest pain, and actually had a cardiac arrest in emerge. And I'll show you her ECG. So here's her ECG, and what you see here is you see, although it's maybe a little more evident to the people sitting near the front, is you see infralateral ST elevation. You see a little bit in V6. And the other thing that you see is she's got a long QT interval. So she arrests, and this actually happened several years ago. So she was defibrillated. She had the ST elevation. They gave her a thrombolytic, and it worked. She got cathed. She had triple vessel disease. She went for bypass. The bypass was uneventful. And then she actually arrested in the recovery phase. And then I saw her, and we were asked to see why did she arrest after we revascularized her and she's got a good heart? What's going on here? And so at the time, that ECG that I showed you, we noticed that not only did she have ST elevation, but she had a long QT interval. So we said, the potassium was 3.1. She was on domperidone. She was taking something like Celexa or something like that. So we said, stop all the drugs that cause this, and that'll shorten her QT, and everything should be fine. So I was at this kind of rounds sitting beside one of our surgeons, and and that was the other thing with her arrest is she had a little bit of ST elevation again. And so we were suspicious maybe she'd occluded a graft. And in our neck of the woods, the surgeons never want to look because, of course, that doesn't usually turn out well. So they said, no, we don't need to cath her. We think we have an explanation. She's probably just nicked off a graft. But we were worried about her QT. So I was sitting at these rounds next to the surgeon. The surgeon said to me, Andrew, You know that lady that you saw last week with the arrest and the QT and the bypass and stuff like that? Can you go see her? The nurses are complaining that the QT didn't get short after we stopped all those drugs. And so I went and talked to her, and I said, you know, have you ever had any kind of heart rhythm problems? Remember, she's a 78-year-old lady who lived at home, independent until this happened, until her first episode of chest pain. And so interestingly, she tells me, and when I look through her ECG, she tells me that no, but she has a niece who has some kind of heart problem, and they're thinking of putting a pacemaker in her. And I said, well, you know, what's her problem? And she said, well, she had fainting spells. So I said, oh, well, what's her name? And she gives me the name of one of my long QT patients. So isn't that interesting? So I say, well, you know, do you have any kids? And she said, no. And I said, well, you know, it's unusual in your generation not to have kids. Did you choose not to have kids, or did you have trouble having kids, or what happened? She said, well, we had a little boy, and he was deaf. And I said, oh, he was deaf. Why was he deaf? He said, oh, because the cord was wrapped around his neck. I said, well, you know, I did go to medical school. I'm pretty sure that when the cord's wrapped around your neck, you don't wake up deaf. That causes other problems. And she said, yeah, he used to faint all the time. He had epilepsy. And then when he was 8, he drowned. Okay? So for people who pick up, you know, so there's something troubling about that story, even though it means something to me and the EPs in the group, but it may not mean something to everybody else. But it turns out her son is a homozygote. He's got 2 long QT genes. And so what's interesting is her husband, who's 11 years older, he's 89, is coming to visit her during this. Says, I don't feel so good, goes down to emerge, has an inferior STEMI, arrests during his STEMI, and we look through the computer, and both of these people have had QTs in the high 400, 480, 460, 480 for the last 25 years. Nobody's ever picked up on it on the computer. Both of these people come together to make a homozygous kid who's deaf, because you need the same potassium channel to conduct for central neural conduction for hearing that you do for cardiac conduction. And so their deaf homozygote kid has Jervell-Lang-Nielsen syndrome and dies suddenly when he's 8. And they only manifest their long QT syndrome when something else comes in. The storm of ischemia comes in and interacts with it. So they've been sitting there lurking with mild long QT syndrome, like the other patients from that large family. They actually have the same mutation as Michael, even though they're not related. And it waits until something comes along, like an acute ischemic event, to then turn into a cardiac arrest. And had we not put the dots together, they would have, of course, been just another coronary patient, right, with a cardiac arrest in the context of acute ischemia. So they're a bad mix. So do I still have a little bit of time? A little bit of time. Okay, so what I want to do now is just try to make the point that in a way that's yesterday's story, and the real question is, where are we going forward? Because if you like, we've picked up the low-hanging fruit of the simple diagnoses, relatively simple diagnoses, and asked ourselves, you know, are the genetics and the way this manifests much more complex? So, you know, we have at least 1 million points of variability, each of us in our DNA, almost all of which is just what makes us interesting and different. But there are some points of variability in our DNA that are potentially influence, if you like, our traits. And so that's not good. There we go. Okay. So if you're feeling a little intellectual, I'd encourage you to read the 2 papers I'm about to show you, both one from Circulation and one from Science. So this is a paper that talks about cardiovascular networks. And this is the notion that our approach to problem solving has a tendency to try to reduce things and simplify things because it helps us get through our day. In the end, you got to see the patient, you got to fill out the prescription, put in the pacemaker, do whatever you need to do. But the reality is there's a limit to how personalized, if you like, that approach will be, because there's so much about the patient that we don't understand. So this is an example of a network. And this is a figure from the paper that talks about all of the things that influence cholesterol or lipid metabolism in a mouse. Okay? So a mouse is a simpler creature than a human being, and we're just talking about lipid metabolism. So this is a very focused, narrow thing. You'd think that'd be pretty simple. This doesn't look very simple. And the beautiful thing is the caption underneath says this is a simplified diagram of lipid metabolism in a mouse. Okay? And if you look at, for example, you take one of these little factors, if you look over here, so this factor here interacts bidirectionally with this factor, unidirectionally but in different directions with several other factors. And that's only one node in this immense network of lipid metabolism. So if I go in and I change this, I'll change this, but then that interacts with this, and so on and so forth. And so if you go into a situation and you say, well, listen, let's do something simple. I've got atrial fibrillation on my hands. And what I want to do is I want to take out one of the potassium channels and see if that helps their fibrillation. So that's what Sotalol is. It's an IKR blocker. It makes sense. We prescribe Sotalol all the time. So what we do is we knock out one of these little things, then we sort of cross our fingers and hope the whole system is a little better and they get less atrial fibrillation. But is there another model for what happens when you block IKR? That's called type 2 long QT syndrome. So you can't be surprised that when you knock out IKR, you get a small number of people who get bad rhythms, because what you've done is you've given them pharmacologic long QT syndrome. So that kind of oversimplified thinking will always leave us with 2 steps forward and 1 step back, because we don't really understand the problem. So here's the next version of this. So this is 3 really smart people at Hopkins who don't know anything about arrhythmias, don't know anything about long QT, but they're computer people. They do modeling for a living. So their project started in 2009. So it took 3 guys, 3 years with supercomputers to come up with this. So they took everything known about all proteins, everything known about all genes, and they put them into a model together to say, what are the things that influence the QT interval? What are the things we know about how proteins and genes interact to create the QT interval? And so they started out with about 11,000 different things, 11,000 of these sort of nodes or network type of things. And what they reduced it down to is the genes that were most likely to be relevant turn out to be the genes that cause long QT syndrome. So that sort of validates the model that they're doing mathematically. But what's interesting is, so that's the sort of, if you like this, that's the town clock tower. But what's interesting is if you then say, well, are there some things that are sort of related but not strongly related? What could those be? So then in the neighborhood, right around, just sort of downtown in this, is about 55 other nodes, 55 related things. So we now have 55 new genes that are not recognized to cause good old-fashioned monogenic long QT syndrome that have something to do with the QT interval. And then we have about another 360 of these nodes that are kind of very weakly related to it. And then most of the others, 95% of the others, have nothing to do with the QT interval. And then, so again, this is a form of, if you like, data mining to look for associations. So you say, well, that sounds kind of interesting, computer-ish, but what does it actually mean? So here's how they applied the results of their experiment. So they looked at the National Registry that looks at adverse drug reactions. And they said, you know, when you get Sotalol or domperidone or cisapride and you get a cardiac arrest, everybody goes, okay, I saw that coming. We know that's how it works. But are there any drugs that appear to cause torsade and cardiac arrest, but they don't appear to have anything to do with the QT interval? They're not known to have any effect on the QT. They don't block potassium channels, that kind of stuff. What could that be? And so they actually took 2 of those drugs. This is a cancer drug, and this is a motility drug that's not supposed to be like the other motility drugs that cause IKR blockade. And we know they don't block the potassium channels. So then they said, well, what nodes do they plug into? What enzymes, what genes, what proteins do they plug into? And of course, so it turns out that, of course, here's loperamide, here's the cancer drug. They affect this node, which then affects this node, which affects this node, that then affects this node, which is one of the long QT genes. And we are not smart enough to think of this in the process and say, oh, okay, I get it. You know, you just jump here, 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 and then you end up with a good explanation. So we just sort of say, oh, I guess it just happens. Okay? So in other words, we need computers to help us deal with the complexity of how these things interact and how you can make the journey from a cancer drug to a cardiac arrest, and it actually makes some biologic sense. So the first steps in this journey, this is an example. So NOS1AP is one of these types of what's called a gene modifier, where it doesn't appear to cause good old-fashioned long QT syndrome and sudden death, but it appears to modify how bad your long QT syndrome is. So this is a study that looked at a whole bunch of patients with long QT syndrome and said, what's weird is you have these people who all have the same gene, but some people have a bad case of it, some people have a mild case of it, called variable phenotype or variable penetrance. And what they did is they said, well, depending on what your variability is at that site in your NOS1AP gene, does that influence how bad your long QT is? So of course it turns out that if you have the long QT gene and you have a longish QT interval and you have the wrong NOS1AP polymorphism or variant in your genes, and this is the case in about 20% of the population, that's a bad combination. These are the people who are at highest risk. Whereas if you have the other, the more common variant, the gene modifier, then you're at lower risk. So we're beginning that journey of understanding how a single gene is a nice, simple explanation in a very small number of cases. But in fact, it's a bunch of different genes and how they interact. It's those network kind of things that explain why things are the way they are, and it's going to be a lot more complicated. So anybody here ever explored personalized medicine? Ever had direct-to-market genetic testing? So if you loved your family, for Christmas you could have got them the Christmas special. So the Christmas special was for $195. You could send either, now they'll take saliva. You don't have to even have to send blood. They'll take saliva. So they send you a kit, you FedEx it back to them, and then they take your saliva and then they send you a report. You see, here's Jack. So he's sort of the baby boomer guy saying, you know, discover about yourself, discover your heritage, you know, take control of your health and understand your genetic risk. And see, they even use buzzwords like empower, right? And so for Christmas, you could get the cancer and the atherosclerosis panel, and then they send you back this report. And the report is a multi-page document with all the PubMed citations of all the papers that have looked at gene association studies and so on. And they say, here is your risk for colon cancer is increased 13%, for prostate cancer reduced by 42%, for breast cancer increased by 7%, for stroke increased by this, for this form of DVT by this, and so on. And then it says, take this report and discuss it with your doctor. Your doctor has no clue what it means, none whatsoever, right? What would you do if the patient brought this to you and say, oh, that's very interesting, you know, we'll put it in the waiting room, right? So the companies are tired of waiting for us to find a direct use for genetic information, so they're marketing to your patients to try to say, take control, understand this. But right now, we don't know what this means. Now, having said that, if I was told I was at twice the risk of prostate cancer and no risk of lung cancer, maybe I'd go get my prostate checked twice as often and smoke more cigars. I don't know. So, you know, there's some biologically plausible things to do with the information, but we have no idea what it means in terms of how it translates into benefit or implications for patients. So in the end, I would describe this journey as, here's your 335,000 Americans who drop dead every year. And if we're lucky, 5% of them survive. So, you know, if we really need to work our way into this population and stop focusing on the people who survive. And in 5% of these people, we have a dominant inherited cause. And what we're trying to do is not only learn from them, but work our way back in these populations so that we can actually understand the population sudden death risk. And that will then begin to identify tools for how to develop prevention. There was a nice little paper in Heart Rhythm you might have seen either just before or just after Christmas about something called a risk watch. And so this is a device that you wear that basically calls 911 if you don't have a pulse. Obviously, it's not a perfect device, or it would have been in Nature or a New England Journal. But the whole notion that we could all walk around with something that's an alert device that could resuscitate us is not a Star Trek kind of thing to do. Some websites that would be of interest, qtdrugs.org lists all the drugs that prolong the QT interval. It's a searchable database run by University of Arizona. Brugada Drugs is the same, run out of Spain. Heart Rhythm Research is actually these are two websites that are related to our work and so on, which includes some stuff for healthcare professionals as well as for patients. So in conclusion then, genes play a huge role in susceptibility to sudden death, for some patients more than others. A careful history and thoughtful approach to problem solving will actually help you to get to the bottom of this for some patients. But genetic testing is coming. Right now, for research purposes, I'm buying the entire exome for a patient. Every bit of genetic information in your DNA for $1,500. Okay? So this notion that it's out there and that it's Star Trekky and that it's coming is completely obsolete. It's here, it's now. It's a matter of accessing it, utilizing it. It's not whether you know something about somebody's genes. So what's going to happen next is your patient will come to you with a little flash drive with their DNA on it. And then they'll say, oh, do you want to look? I'm having a little trouble breathing when I get a cold. I might have asthma. Do you want to look at my asthma genes? Here's my flash drive. You know, or my mother's having dizzy spells. Here's her DNA. What do you think? So I mean, that's a frightening thought, but it's also a very fascinating and interesting thought about trying to understand things. Because I think when it all comes down to it, with the complexity of biologic systems, we actually understand relatively little. We're not as smart as we think we are. Anyway, on that humble note, I say thank you. Are there any questions?
Any questions?
Looking at all these diagrams, it sounds like it's so complicated. Even if you identify a gene, that's not the whole story. You still have a long way to go.
I mean, if you think about, the thing that we have a difficult time measuring and influencing is environment, right? So, how much does pollution matter? How much does renal function, electrolytes matter? How much do microconstituents in our diet matter? Those kind of things. And it's probably because we don't have a good handle on how to measure that we haven't thought that that's relevant. But it likely is. And that's why the long version of this talk that I have goes into a little bit of that networking theory and the use of computers to try to capture the kind of information none of us are smart enough to keep in our head all at once. Because I think that's really where the future is.
Thank you very much, Andrew. I have a question regarding that long QT that appears during cardiac ischemia, because we see this a lot in the CCU.
Yeah.
And it becomes a mind-boggling thing, particularly if the patient will have, like your patient who had a spasm. Do this patient's beta blocker is definitely a treatment. Do you still give them ICD or not?
Yeah. So, I mean, if you look at, again, if you take it on a population basis, if you have somebody who arrests in the context of acute ischemia, the driver is their ischemic burden and their LV function. That's still the population basis. So we will still generally not put an ICD in somebody who arrests in the context of acute ischemia. Best medical therapy obviously reduces risk and so on. I think the real question is, and we're actually studying this right now, is what happens in the outcome. We know patients, for instance, who have marked QT prolongation with their infarctions, they have a worse outcome. And so we're actually now tracking the outcome of that to see whether their QT resolves. And it generally does, but there's actually less known about that. That's another sort of active area of research.
Correct, and I found that women tend to have more long QT prolongation during ischemia than men. And then you've got the dilemma when a lot of people give them amiodarone, which increases the long QT as well. And you're in the middle. Shouldn't we? And I think we tell them, let's fix the vessel. Let's see if we can get back to normalization of the long QT. But I think it's a big dilemma.
Yeah, it is a dilemma for sure.
Any other questions?
Just one question regarding that, going back to the family members, because as Dr. Aziz was mentioning, like, we do see a lot of prolonged QT during ischemia, or maybe inadvertently during some medications, but I mean, I'm just my first year cardiology fellow, but I've never gone back in details. I never spoke about a family or brothers or sisters. I've never contacted them or never told them to contact them and see them. So how often do you do that when you observe them in the CCU or in your general cardiology, like with ischemia or maybe just these medications?
So we have a protocol we're running right now where our automated ECG analysis system actually tells me every day how many patients have a corrected QT interval more than 550 milliseconds. Believe it or not, that's about 2 a day. So there's a remarkable number of patients in the hospital who have long QT intervals. Most of them are catastrophically ill. So they're infarction or they're in ICU or they're in the stroke unit or those kind of things. What we're doing right now that we're tracking, and I don't have any outcome data for you, is we're saying, all these patients should be followed out to 3 months with an ECG. And if they don't have normalization of their QT interval, then they undergo essentially a familial long QT workup. So they undergo a stress test, and then their family members are contacted and offered screening and so on. I can say on an anecdotal basis, because we've only been doing this for about a year, that once in a while you'll pick something up, but most of the time these things resolve.
Any other questions? Well, I thank you very much,
Okay.
Andrew.
Thanks for the invite.
Thank you. So I think, guys, you've heard it all from beautiful 3 speakers. Thank you very much for coming, and please enjoy the food, and we'll see you next year.